Good morning, everyone. I'm back. Mr. Dipple this morning talking about management of head and eye injured patients. ELO's action identify critical components in the management of patients with neuro injuries and implications of in-route care. Standards, we're going to identify critical concerns for appropriate management of neuro patients, in-route care specified in the JTS, CPGs, and service protocols. Administrative data for today's class. And we're going to start off with management of eye injuries. As many as 30% of all head injury patients in the combat may have an associated eye injury. In general, it is definitely better for prevention than it is for treatment. You know, everyone who's deployed has always had to wear your eye probe when you go to the range, wear your eye probe. Everything you do, wear your eye probe. That is that prevention piece that we would prefer to prevent eye injuries than treat eye injuries. Back when I was in the Army, we used to do the old wrap. If you had an eye injury, it used to be wrap both eyes, Curlex around the head. Soldiers couldn't see anything from that point on. Kind of gotten away from some of that treatment techniques, and now we're doing just the old shield and ship. All right, shield and ship. That is the new terminology that is out there, and that is what we want you guys to focus on when you're dealing with all type of eye injuries. Shield and ship. The chemical injury, obviously you want to begin to irrigate it, obtain a history, dress wherever possible. Also, if you can keep their ballistic eyewear, you can use that as a shield and ship technique, and then check visual acuity in each eye separately. Shield and ship. Avoid any maneuvers that place pressure on the globe. We don't want to be packing it down with gauze. In fact, this Fox eye shield that you see here on the bottom of the screen is actually rounded in nature. You're going to place that directly over the eye. There is some technique where you can put some tape around the edge. Sometimes those things can be a little bit sharp, but you definitely don't want to put any pressure on that globe. Do not place any dressing that can touch the injured eye. If there's anything, you're going to have to pat around it and then put the shield over it. All right. Do not place a head wrap over the unshielded eye. All right. Use either a rigid eye shield or an alternate, such as a cup. Casualties own ballistic eyewear, like I talked about, or any other expedient device that does not place pressure on the globe. Again, ladies and gentlemen, we just want to cover it with the most appropriate means necessary, and then we're going to shield and ship. Patching both eyes to decrease, that's actually me in that bottom right-hand corner. I'm just kidding, it's not me. Patching both eyes to decrease the sympathetic eye movement has not been shown to improve visual outcome. All right, you cover both eyes, then the patient is unable to move independently, may increase anxiety. I know I'm scared of the dark, so if you cover both my eyes, that's going to be an issue for me. It may put the patient and the provider in a increased risk in the prolonged field care environment. The use of standard eye protection during patient transport can reduce the risk of further ocular injury, and eye protection can be used over a rigid shield to increase protection. Bottom line up front, we're going to do what? Captain Battles. All injured eyes should have the blank and blank treatment philosophy. Captain Battles.
Shield and ship.
Thank you very much. See, we have just completed the first block of instruction, and it is Thursday at 8:36. You guys are hot on it right now. Shield and ship. So, when I went to the Flight Meta course and started this endeavor some 20-odd years ago, this is actually how small my brain was. Notice I still have the same mustache. All right, we're going to ask a couple questions here, and we're going to start talking about head and neurological injuries. I want to open this up for some discussion. And I got name tapes here without your rank, so I'm going to go with Captain Wynn. If it's Major, I apologize. Captain Wynn, how does the in-route care provider assess initial level of consciousness? Just in your own words, how does an en-route care provider assess initial level of consciousness?
So I'm gonna get their score on 0 to 15, whether or not they're talking to you, their head is moving, their eyes moving, they can respond to commands, if they know where they are. Those are kinds of the main things that you're going to look at, like ask them who they are, if they know what day it is, things like that.
Okay. So AVPU, right? All the things that you're talking about, that's 100% alert, verbal, pain, unresponsive, right? We're going to start getting that general history, seeing if they can tell us, who they are, where they are, the who, what, why, when, all that stuff. All right. Sorry, Yanez. What's the lowest number on a Glasgow-Coma scale?
It's going to be a 3, sir.
3. See, you guys are already ready, man. You guys are en-route care providers. With just these 2 questions, I think you're ready to just go out and start dealing with the Monroe-Kelly hypothesis. What do you think? All right. What are the fundamentals of a emergent neuro assessment, Captain Rose? What are the fundamentals of an emergent neuro assessment in your own words?
Well, I'm not going to go through the whole. Well, maybe I am going to go through a 12 cranial nerves, but probably not for emergent. We're going with sensation, moving function, and GCS.
Okay. So, rapidly identify the clinical signs and symptoms of a TBI and associated traumatic injuries and assess TBI severity. So, we're looking at the traumatic brain injury signs and symptoms, doing the fundamentals. This is straight out of the CPG, right? And then track the progression, right? So, a lot of times when we're dealing with head injuries, it could be slow onset, it could be sudden onset. We can see deterioration over time, right? So we're going to track the progression of the injury over time and be vigilant with early signs of rising intracranial pressure, worsening headache, focal neurological deficits, and declining neurological exam, right? That's just some textbook stuff for you. I know everybody knows how to do it, just giving it to you right off the book there. All right, so TBI occurs when external mechanism force impact the head and cause an acceleration or deceleration with the vault. You guys have heard the coup contra coup concept, all right? And TBI may be closed, blunt or blast trauma, or even open and penetrating trauma, right? Regardless of the mechanism, your takeaway is there's 2 types of injuries that occur with a TBI. There's a primary injury and a secondary injury. When severe, the secondary injury can lead to massive swelling, compression of the brainstem, and ultimately death. Thus, the primary focus of TBI management is to limiting the effects of the secondary injury. We can't do anything about the primary injury. We were called because they had a primary injury. Our goal as en-route care providers is to manage the effects of the secondary brain injury. Captain Rosales, can you explain in your own words your definition of the Monroe-Kelly hypothesis, please?
I read it, Mr. Dibble, but at this moment, I can't remember. I just had a good day born this morning, so my head's kind of not there.
That's okay. We'll ask somebody else and come back to you. You're going to remember it. You're going to remember it here in a second. Captain Schuler, can you explain to me in your words the Monroe-Kelly hypothesis?
If I remember correctly, can't remember if I'm mixing up maybe with the primary secondary, but is it where like the swelling and the pressure of the brain is trying to put, so like if I have a swelling on the right side of my brain, it's actually going to be pushing it to the left side, so it's going to be causing a certain damage to the the cranial nerves on that side.
Okay, we're close.
Basically, when the space is displaced,
there you go. Talk it out.
By hematoma or maybe shrapnel being inside of there or something like that. So basically, the cranial pressure has changed. Am I
You're
on the
right.
right track?
Yep, you're starting to put it all together. You're coming in there pretty good, Captain Schuler. So yeah, so Monroe-Kelly hypothesis is your brain vault is only so big, and if something else intrudes that spot, other things have to be displaced. Okay, so the concept of the Monroe-Kelly hypothesis is that 80% of your vault is filled by the brain. 10% of the vault is filled with cerebral spinal fluid, and the other 10% is blood. Whenever something intrudes that vault, right, whenever there's either shrapnel or swelling, then something else has to go, okay, whenever that space is displaced. For the record, the first thing to go whenever we have swelling or shrapnel, whenever that space is displaced, we lose cerebral spinal fluid, okay? Second, we start to lose venous, and we lose blood, and then in the order we lose venous, and then arterial, right, begins to be displaced. So that's the Monroe-Kelly hypothesis. Does anybody have any questions on that at this time? All right, nothing heard or typed. Excellent. That should be a good review for you guys. Differential diagnosis and assessment of a head injury. So TBI severity, GCS score, right? So we talked about the GCS. We talked about the lowest scores of 3. So a mild TBI would be 13 to 15 on your Glasgow Coma scale. Moderate would be 9 to 12. And then a severe would be 3 to 8. And we've all should have remembered the terminology less than 8, intubate, right? So whenever we're dealing with somebody with a severe head injury, we obviously want to start taking over all of the primary functions, airway management, ventilation, things like that, because they may not be able to maintain those if it continues. Signs and symptoms of a moderate to severe head injury. All right. Witnessed LOC, combative behavior, unequal pupils, seizures, repeated vomiting, or you guys have heard of projectile vomiting, double vision, headache, weakness on one side, abnormal speech, right? That's why when I was listening to that video, I thought that maybe I'd had a mild TBI because I noticed a little bit of slurring, but we realized that I just have a lisp. So, moving on. Differential diagnosis, an assessment of the head injury. So do your initial assessment, right? We always going to work with resuscitation first, right? So if they're bleeding, we got to fix the bleeding. If they don't have an airway, we need to fix the airway. We need to breathe for them if possible, right? So we're going to go through our March assessment. We're going to maintain all of the primary focuses of our ABCs, and then we need to identify whether or not this patient has a head injury. It's very important when you do your AVPU and GCS assessment, right? Because if we're doing a transfer, we need to know are they paralyzed or non-paralyzed. It's very difficult to do a neuro assessment on a paralyzed patient, right? With non-paralyzed patients, it's very easy. Check their mental status, like we've talked about. I know someone talked about the cranial nerves. All right, you got pearl, motor, sensory, you got all of those things, right? With non-paralyzed patients, it's very simple. How hard do you guys think it is with a paralyzed patient? Let's find out. For intubated and paralyzed patients, it kind of leaves us only 2 options, right? The windows to the soul, your Pearl exam, and vital signs. That is what we become limited to. So transferring a head injury patient from one role to another to go see the neurologist, you're very limited in your ability to do your full neuro assessment. So we really want to focus on Pearl assessments continuously and monitoring and trending vital signs. Do not forget my 10% rule that we talked about. All right, 10% change up or down can lead us down a path that may give us early recognition that something is going on. You always want to consider C-spine. The incidence of brain and spinal cord injury and trauma ranges from 25 to 60%. Right? So ensure the C-collar does not, but you want to make sure that C-collar does not compress the jugular veins because this can worsen ICP. Remember the Monroe-Kelly hypothesis, right? First is spinal fluid after the swelling starts. Next is the blood. But with the blood, the first thing that goes is the venous, right? So we can, if we're occluding the jugular veins from getting, allowing some of that blood to go, we can actually cause a significant brain herniation very fast. It can definitely worsen the ICP. Close control of end tidal is severe, and with TBI patients, we want to make sure that we are monitoring our end tidal CO2. Plan and ensure the capability to monitor your end tidal CO is available whenever an advanced airway is placed. So the goal, we're going to talk about 2 sets of numbers during this class. I want to make sure that we're all on the same page. For people who have a documented TBI, right, without herniation, right, they just have a documented head injury, we want to maintain a good end tidal CO2 of 35 to 40, right? Sergeant Seidel, what's the normal range for end tidal?
35 to 45?
That's correct, 35 to 45. So we're not asking you to do anything outside the normal. We just want to maintain kind of on that low end, 35 to 40. Good. The neurological exam is essential to identify deterioration in the TBI patient. Treat for elevated ICP for any deterioration with neurological exam findings. So we're monitoring our 35 to 40. We're going to do serial assessments. And we've already discussed that our serial assessments are Pearl exams and vital signs. And then remember, pain medication and sedation are usually required for TBI. So these medications can also make it difficult to follow your neurological exam. So you have to put the whole picture together. Let's do some check on learning. Captain Angelotti, regardless of the mechanism, 2 categories of injury occur with TBI. What are the 2 injuries that occur?
That would be the primary and secondary.
Excellent. Primary and secondary. Good job. Captain Colleen, for intubated patients, what means of assessment are available for the provider? How do we assess an intubated, sedated patient?
You can check the pupils for reaction to light and vital signs, but that's about it.
That's it. Thank you. Pearl and vital signs. That's our main assessment tools. Excellent. Now we're going to talk about some management of head injuries in ICP. Management of patients with TBI should focus on hemodynamics, airway breathing, and ICP management. Okay? Hemodynamic control is to maintain a systolic blood pressure greater than 110, which may lead to a better outcome for your TBI patient. Right? We're going to talk about systolic blood pressures, and we're going to talk about MAPs. Right? Hypotension is usually not caused by TBI. Hypotension is usually not caused by TBI, except as a late finding due to herniation. Right? So you must consider other causes. So if you have a patient with a head injury and their blood pressure starts to drop, right, we need to determine, is it because they're bleeding somewhere else? Is it because maybe we gave them too much pain medicine and they weren't stable enough? We have to figure out why hypotension is occurring. Or we completely missed our trends of worsening TBI, and now our patient is circling the drain. You want to avoid colloids and heterostarches in TBI patients. However, they can be used if there's no alternates available. And avoid hypotonic fluids such as ringers. Whenever possible, that can make the brain swelling worse. Manually maintain and secure the patient's airway and avoid hypoxia, hypocapnia, and hypercapnia to reduce the risk of secondary brain swelling. Patients with a GCS of less than 8 should undergo a placement of advanced airway management. We said less than 8, intubate. Maintain end tidal and adjust ventilation to achieve a 35 to 40. We're going to work towards numbers with these patients, right? So adjusting ventilations, right? So, Staff Sergeant Dumont, how do we adjust? Do we increase or decrease respirations if we want to get our end tidal lower? And if our end tidal was at 45, how many respirations how would you adjust your respirations on the vent to get them to 35 to 40?
So if you're trying to lower this end tidal CO2, you're going to want to increase your respirations and blow off that CO2. And if I was doing it, if it was sitting at around 45 right now, I was probably, I'd say, rough estimate bagging at around probably 14, 15 a minute. So then I would just increase that up to about 18 and see where that gets me. Maybe 16, just a little bit, just to see where it bumps it up to or down to.
Good. Yeah, that's right. So, guys, remember the respiratory buffer system is the fastest way to offload. And if your patient's on a vent at 12 to 14 breaths a minute, whatever, and you want to get your end-tidal down, 3 points, 5 points, something along those lines, it only takes a couple respirations additionally a minute to get that patient down. So we don't need to go from 10 to 12 to 20 to 24, all right, to get our end-tidal down. Just increase it 1 or 2 respirations a minute, and you will see that your end-tidal will begin to drop. So we don't have to go so drastic, all right? Gastric decompression with an NG tube or oral gastric tube will decrease the risk of aspiration in your unconscious patients. We talked about earlier in one of my presentations, anytime we're transporting a patient who is intubated, we always want to prepare them for transport with an NG tube. Remember, Boyle's balloon, as we go up in altitude, gas will expand, so we want to allow that off gas. Always want to suspect a high ICP in any head injury patients with a GCS of less than 8 or declining findings on a neuro exam, unless that can be explained by sedation or other factors. Think about Cushing's triad, all right? It's an increase in systolic blood pressure, widening pulse pressures, and bradycardia, and irregular respirations. It's a response that can occur with elevated ICPs, resulting in compression. Right? It is a very, very late finding with severe brain injury with brainstem herniation. Cushing's triad should be viewed as a sign of impending cerebral herniation and must be addressed immediately when recognized. Okay, and we'll talk about that further when we get into the management of an ICP patient. Captain Rosal is going to come back at you one more time. And if we have an intubated, paralyzed patient, which of those 3 indicators is going to be difficult to recognize when we're looking at bullet A? Which one is going to be difficult to recognize when it comes to the Cushing's triad? Talking about increased systolic or widening pressures, bradycardia, and irregular respirations.
So you're asking me, how is it hard to detect, or what am I looking for? How do I know if it's going to be Cushing's?
No, ma'am. What I'm asking for is on an intubated, ventilated patient, which one's going to be most difficult to detect?
Well, I know that they're unresponsive, so you're not going to be able to get any response from them. The blood pressures with Cushing, sometimes we know that it's not normally caused by the regular hypertension. So.
Okay. So what I was trying to get, and what I'm looking for is so there's 3 sets of vital signs that tell us if our patient's trending towards herniation, towards that Cushing's triad. And we can monitor blood pressure on an intubated, ventilated, paralyzed patient. We can see bradycardia, but it's hard to catch those irregular respirations because they're on the vent and we're kind of controlling that. So that's really you're kind of limited now on your ventilated patients during transport at looking at respirations, because that's one of the 3 that we're controlling. So that really leaves you to blood pressure, heart rate, and a good neuro exam. That's going to be kind of our ability to recognize during management. Management. Let's minimize the factors that contribute to elevated ICP, such as pain, anxiety, and fever. rapidly recognize and manage ICP and maintain adequate CPP or cerebral pressure, perfusion pressure. ICP cannot be directly measured without advanced intracranial monitoring devices. Right? There's no way for us to measure that unless we have something up there to help us. Right? So patients with observed neurological deficits have an assumed ICP of greater than 20. All right? We assume that their ICP pressure is greater than 20. Any change, GCS, greater than 2 is a possible sign of intracranial pressure. Intracranial pressure monitoring is recommended for most patients with severe TBI. Anytime we're in that 3 to 8 category, it's recommended on your GCS, it's recommended that we have some type of monitoring device for patients who have a noted TBI injury. Options for ICP monitoring include external ventricular drains, and that is an example of one down there in the bottom right-hand corner. And currently the Codman ICP monitor is the only device with aeromedical certification, right? So that Codman, if you're going to put them in a rotary wing aircraft, right now that's the only one that you have an option for. We have an example of that at the DTC. You come down for simulation, you'll get to play with it. The goal for ICP is less than 22, right? That's our goal. Target cerebral perfusion pressure, or CPP, for severe and favorable outcomes is between 60 to 70 CPP, all right? Whether, and this is in the studies out there in the CPGs, whether 60 or 70 is the minimum optimal CPP is unclear. It may depend on the status of the patient, right? So we want to maintain 60 to 70. Right? Remember, there's a formula for you that's going to come into play, especially when you start doing your simulation, is that MAP minus your ICP equals your CPP. And if you forget how to get your MAP, there's a formula down there for you. Systolic, right, plus 2 times the diastolic divided by 3 gives you your mean arterial pressure. And then you minus your ICP, and that'll give you your CPP. So doing a little, putting this all together here, we said if we have a patient who has a known TBI, we assume that every patient has an ICP of at least 20, right? And we want to maintain a CPP of 60 to 70, right? So you would do your MAP minus at least 20, because we assume that all head injury patients have an ICP of 20, equals your CPP, right? We're going to practice this a lot in our simulations, so you might want to write that down. Consider prophylactic anti-epileptic medications, right? Seizures are not uncommon with severe brain trauma, right? So we really want to consider getting some anticonvulsant prophylaxis on board before putting them in the aircraft. Right? Give anti-epileptic medication for seizure prophylaxis for the first 7 days after a moderate or severe TBI. So if I'm going to a facility and I'm picking up a patient who I know is a known head injury, even if they have the mechanism of a head, maybe they were involved in a blast, right? That's the mechanism that could lead to a head injury down the road, right? We might want to consider giving them anti-epileptic medication before putting them in our aircraft. If you witness or suspect seizure activity while in flight, you're going to administer Versed 5 milligrams IV IOIM every 5 minutes until the seizure stops. If that benzo is not available for you, you have other benzos. Diazepam is an example, 5 milligrams IV, or lorazepam, 4 milligrams IV every 5 minutes until the seizure stops. Monitor glucose every 6 hours. Goal is to maintain a glucose less than 180, but avoid hypoglycemia. Right? Steroids should definitely be avoided in head injury patients, as they have not shown outcome benefits and increase mortality in patients with a severe head injury. All right, check on learning. Cat Manzo, hypotension is a normal sign of ICP in head injury patients. True or false?
That is false.
That is false, right? If you have hypotension, we want to start looking and considering other causes, all right? How do we treat hypotension, Captain Manto?
Well, it would depend on what's causing it. Sometimes it's going to be fluids.
Yeah, most likely it's going to be blood and fluids. That's correct. That's what I was looking for, especially in our damage control resuscitative patients. We always want to try to fill the tank first. Excellent. What is the goal of ICP, Captain Battles?
Less than 22.
Excellent. Thank you. Excellent. Captain Rose, CPP equals.
Our target is 60 to 70, or are you looking for the calculation?
I'm looking for the calculation. CPP equals.
MAP minus ICP.
Excellent. Excuse me. Very good. All right. LSA 4. We're going to talk about management of these patients in flight a little more in depth. In-route care management of our head injury patients with ICP. We're going to work in an environment which is non-conducive to head injury patients. All right. I know somebody has got their mic on, by the way. When you think about all of the times when you went up to the ICU floor in a hospital, right? The neuro ICU, right? Can somebody give me an example? Let's do Captain Colleen. Give me an example of what the neuro ICU floor environment is like.
Yes, it's very quiet, very dark, very calm setting. I think, very plain.
Yeah. You're right, Captain Colleen. It's dark. It's typically quiet. It's cool, right? And the environment that we're asking you to work in is the exact opposite of everything that is on a neuro ICU floor. Would you agree, sir?
Totally, yes.
Totally agree. Yeah. The environment in which we're going to be doing these transports include vibration, typically warmer temperatures, noise, movement, light, right? All which are not great environments for our neuro patients. Observation in theater may be warranted for patients with borderline ICP. It has been noted in the CPGs that ICP monitoring is recommended during aeromedical evacuation for patients who would meet the requirements. Okay. Dose sedative analgesic medications, osmotic agents, and or other benzos before any significant ground or air transportation as resources permit. All right. So we're going to, I don't want to use the word over medicate, all right, but we're going to ensure proper dosing of all of our sedatives and analgesics for all of our patients before we put them in that aeromedical evacuation environment. Sedation considerations, all right? So propofol is the preferred sedation, all right, for all head injury patients. Propofol is the preferred sedation for all head injury patients. Consider the administration of a rapid onset, short duration, benzo like Versed, all right? And VEC is the preferred for paralysis because it is rapidly available in the far-forward environment and it doesn't require refrigeration. Not a lot of refrigerators on my helicopters. All right. If there was, all right, we'd have a lot of cold refreshments like Coke, Pepsi, stuff like that. Boluses dosing is preferred over continuous infusion. All right. There was actually a good conversation on the JTS-TCON this morning. They were talking about the environment in which we do in-route care management. We always do a lot of bolus and IV push over infusion management. They stated the cause was because of the pumps are not always as effective or reliable. The vibration can sometimes cause additional air bubbles in your pump tubing. I will concur with that. Some of it also goes to the inexperience and inability for in-route care providers, the comfortability of in-route care providers to use those pumps in that environment. All right. in general, flight paramedics like myself, we don't get a lot of practice using IV pump therapy, right? Because most of our transport times are 15, 20, 30 minutes. And so sometimes setting the pump up isn't worth it, right? We'll just IV bolus. Nurses, that's where you guys really come into play, is because that is your wheelhouse. Whenever I have a pump question, I look right at Major Speed and I say, ma'am, you need to hook me up, because it's not my wheelhouse. And that's why I really think the team of a nurse and flight medic is so excellent, because we both bring something different to the table, but I'm going to get it off my soapbox. So bolus dosing is preferred over continuous infusion. Keep in mind, neuromuscular blocking agents will mask seizures in clinical examination changes. Therefore, the risk versus benefit of using during transport must be considered. Staff Sergeant Dumont, if I have an intubated, sedated, paralyzed patient, how would I be able to identify a seizure in transport in the back of a rotary wing aircraft?
It's fairly hard to identify it. You might be able, if you're paying close enough attention, the flickering of the eyelids, possibly, or significant increase possibly in their pulse.
Okay. See, now we're starting to think. You're 100% correct. So 10% rule, right? The 10% rule. If I have a seizure, what does my heart rate do? Goes up, right? My heart rate goes up. What about my blood pressure? Does it go down, or is it going to go up? It's going to go up, right? So vital sign changes can lead me down a path that my patient may be having a seizure. The problem with this is that we're always playing true detective. I talked about this before, right? Whenever you start to see a spike, you have to ask yourself, is my patient in pain? Is my patient bleeding? Is my patient having a seizure? You have to start putting the pieces of the pie together. If I just dosed pain sedation 5 minutes ago, and then all of a sudden my patient starts to spike, did I give the right amount of pain medicine? Or is my patient now having a seizure? Captain Schuler, if I just gave 100 mics of fentanyl for pain and 5 milligrams of Versed for sedation, and 5 minutes later, my patient starts to have a seizure, what's my dose of Versed?
Dose of Versed, and you just gave fentanyl, and you just gave, what was the other medication?
I just gave 100 mics of fentanyl, and I just gave 5 milligrams of Versed for sedation, and my patient starts to, and I think my patient's having a seizure. What should I do?
Wouldn't midazolam be the preferred medication, 1 to 2 milligrams?
It would be the preferred medication. That's correct. So what I wanted to emphasize is just because you gave it for sedation and now your patient starts to have a seizure, you still need to give a benzo to stop the seizure. That's the point of the story. Thank you, sir.
After that.
Pain management with intermittent narcotics is preferred over continuous infusion. Again, intermittent narcotics over continuous infusion. Ketamine, 20 milligrams IVIO, fentanyl, 25 to 50 mics, IVIO pushes, okay? Hydromorphine, 0.5 to 2, IV push. With signs and symptoms of declining in neurological status, perform the following actions. These are our management steps for the in and out care provider in the aircraft, all right? If our patient is showing signs of increased intracranial pressure, elevate the head of bed 30 to 60 degrees. Make sure we're maintaining the neck in a midline position. Don't forget, if we have a C-collar in place, ensure that it is not too tight that it could detract from venous return. Maintain arterial blood oxygen supply. For all patients on ventilatory support, that should be greater than 95% SpO2. Maintain an end tidal between 35 to 40. maintain core temp between 96 and 99, and maintain a systolic blood pressure of 90 and ideally greater than 110, prevent or rapidly manage seizure activity. This is all of our management steps for a patient with ICP. All of our management steps for a patient with ICP. There'll be a few changes here in a few slides if we talk about worsening. If concerned for impending herniation, unresponsive patient with unilateral pupil dilation, presence of Cushing's triad, then it says hyperventilate the patient with no more than 20 minutes to an end-tidal target of 30. We're going to, I don't really like the word hyperventilate. That is out of the textbook. But really what we want to do is ventilate, and that's the word I want us to focus on. Ventilate our patient to a target end-tidal of 30 for an end-tidal CO2. Remember, we talked about we're not going to go from 12 respirations a minute straight up to 24 respirations a minute, right? We should have already been maintaining 35 to 40 for all of our ICP patients. If we see signs of herniation, we should only need to increase our respiratory rate up a few respirations a minute to get our end-tidal down into that 30 range. Right? We're going to consider the administration of osmotic therapy. All right, IV or IO. We're going to give 3%. All right, there are 2 doses for 3% here. The reason why I share 2 doses with you is because 1 dose in the SMOG and then the other dose in the CPG for prolonged field care. All right, so consider 250 milliliter bolus of 3%, and then infuse 3% saline, 50 to 100 milliliters an hour for resuscitation. If you're an ECCN, critical care flight nurse, and you're flying on a medevac aircraft, that is your SMOG dose. Right? And I want to point that out for you. The first one is your SMOG dose. Right? If you're following CPG guidelines, or maybe you arrive at a facility to transport a patient and they're using these guidelines, you may see 3% bolus over 20 minutes, repeat every 3 hours as needed. All right. So you may see that bottom dose if you're picking up in a prolonged field care environment. But note, for medevac, for SMOG, the first dose is your dose of choice. Mannitol can be used if there is no sign of bleeding and the systolic blood pressure is greater than 110. However, all right, you need to be concerned with mannitol with patients who may be presenting signs of hypotension. Right? That can make it worse. Check on learning. Captain Wynn, what factors should be considered when moving patients with suspected ICP, especially in the aeromedical environment?
So noise, movement, light, what altitude is going to do to their oxygenation, and the vibration is going to do to their ICP, and then whether or not you can keep them warm enough, and their oxygen levels.
Exactly. A lot of environmental considerations for aeromedical evacuation. All right, something I also want to point out that you brought up was the altitude. All right, we can also, if we recognize, when we start talking about patient packaging and moving our patients for when we get in class and I give you that lecture, you're going to hear me talk about working with medevac as a team, right? Sometimes we get lost in the moment that we're transporting a patient and it's the nurse and the medic, and we got everything covered. We got this covered, right? But you also have pilots up front, right? And your pilots need to be involved in the planning factors of your medevac mission, because if you have a head injury patient, you may want to mention to your pilots, hey, Mr. Smith, we've got a head injury patient. Could you plan your flight altitude the lowest and safest possible to get us to our destination? We don't want to just jump up to, 10,000 feet and fly because we have a head injury, right? So these factors are important to communicate with your whole crew, not just your partner in the back of the aircraft. So very good to recognize that. Captain Rosales, what is preferred for sedation and what is preferred for paralysis when dealing with a neurological patient with a TBI?
Ketamine and Versed. And then you can use for seizures any type of like diazepam or Versed as well.
Okay.
And then we can also use VEC also if we need to keep them sedated.
That's right. So for sedation, the preferred drug for sedation is propofol. Remember, the preferred drug for sedation for a patient with a head injury is propofol. And then for paralysis, you're 100% correct. The preferred drug is becaronium. Excellent. Okay. Sergeant Seidel, with signs and symptoms of declining neurological status, what actions are we going to perform?
First of all, I apologize if you hear my son in the background. He's with me today. But first I'd say, so putting the head of bed at like 30 degrees, and then keeping your end tidal, depending on where it's at, 35 to 40. And then monitoring heart rate or signs of seizures, and then giving any types of either hypertonic saline or I forgot the other one. Yeah, that's where we'll go.
Okay. So right on for the most part, but remember with declining, right? And that actually, my slide is actually wrong. It should say 30 to 35, right? So check on learning, right? Head of bed, 30 to 6 degrees. Maintain an end tidal. And note class, it should say 30 to 35. And then administer osmotic therapy, 3% or mannitol. Good. There is a head injury protocol in the SMOG, right, that you'll be able to follow. And all of the numbers and things that we talked about, the drugs and dosing, will be found on that protocol. And I'm going to open it up at this time for any questions.